So today I'm going to talk about osteonecrosis of the jaw. I like the terms that are self-explanatory, like this one. So let's break it up. So osteo means bone, necrosis means death. So it means the death of the jawbone. Before we talk about osteonecrosis of the jaw, I would like to clear some confusion that has arisen because there are different terms used for the same problem, that is for osteonecrosis. There have been different terms since the year 2013, and the reason why these terms have changed over a period of time. So initially when we saw the death of the jawbone happening, so it was seen in patients who were receiving the medication that was the bisphosphonate group of drugs. Hence the term was coined that bisphosphonate related osteonecrosis of the jaw. Later on, when there were some clinical trials happening, they found that there were different group of medications which caused the death of the jawbone. It was not just specific to the bisphosphonates. Hence, it was a term that was now used was medication-related osteonecrosis of the jaw. Furthermore, it was seen that patients who had a history of radiation also had a similar condition. So in patients who have a history of radiation and have the death of the jawbone, there was a term that was used that was medication-related osteoradionecrosis of the jaw. So this was all about the confusion or the different terms that have been coined over a period of years. So let's talk about the osteonecrosis of the jaw now. So the drugs like Fosamax, Ring-class Boniva, which are the bisphosphonate group of drugs, and also the denosumab, that is the RANK inhibitor, have been associated with the condition that causes the death of the jawbone, that is the osteonecrosis of the jaw. And the risk of this condition for someone who is on a drug for osteoporosis is extremely low. But what the evidence-based study shows that the people who have had these medications intravenously with a class of drugs like the zoledronic acid, that is the ring class, in a very high dose and maybe monthly or every couple of months for a different condition, namely cancer, where these drugs are actually very useful in making the bone resist the cancer. These patients are a small percentage of the population who develop ONJ. In the osteoporosis population, it is very rare, but it does happen. So that is what the evidence-based studies have shown, that with osteoporosis, the population it's quite low, whereas with the cancer population it's quite significantly higher. So what is osteonecrosis of the jaw and why does it happen? The jawbone actually is a very active bone and it's turning over itself frequently, like it's replenishing itself and renewing itself all the time. And the jawbone is very close to the mouth, and the mouth is full of bacteria. So the jawbone has to fight the bacteria that might sneak in through the gum. So in such a condition, when you have frequent infusions of intravenous class of this medication, these medications, they love the bone, so they would just go and sit right next to the bone, and it reduces the ability of the jawbone to what we call as turnover. So if you then go and have a tooth pulled out, a piece of the bone is now exposed to the air. So sometimes this bone has trouble healing and it ends up getting infected by the bacteria in the mouth. The problem is in the bone, but it's now leading to an open wound. Some people may have this happen in a cancer situation, typically while getting a tooth pulled out or when an implant is placed. It doesn't happen when a teeth is cleaned or a cavity is fixed, but it's going to happen when the bone is exposed for some reason and it does not heal well. In osteoporosis population, it happens, but it's not very common. So why are these medications used? So if the patient is at a significant risk of breaking bones, and you can reduce the risk by half, which is what these drugs actually do. So when you compare the benefit and the risk ratio, the benefit overwhelmingly outweighs the risk of the small risk of having osteonecrosis of the jaw. So initially, they use something that we call as a CTX test to predict if the patient would have osteonecrosis of the jaw, but the clinical trials have proved that the CTX is not useful in determining whether the patient is at risk of ONJ. So what the evidence-based has shown is that you see the overall risk factors in the patient. So you would see different risk factors, like the local risk factors that is related to the oral hygiene, mouth, or any appliance in the mouth which might be irritating the soft tissue, or it could be a systemic risk factor like diabetes or any steroid therapy or cancer therapy, which is going to reduce the immune system for the patient. So again, he's going to be at a higher risk of having ONJ. Or the drug related factors, like similarly when it's at a higher dose, or certain group of drugs like the zoledronic acid and the intravenous medication. So this population is going to be at a higher risk. The reason why these guidelines were released is because a clinician has to have a judgment and understand whether the patient is at a higher risk or a lower risk. So he has to see the overall patient profile. According to the guidelines, he has to use his clinical judgment and knowledge, and it can be done with a team of oral maxillofacial surgeon and the general practitioner to assess if the patient may have the risk of ONJ. Also, initially they used something called as drug holiday, where for any invasive procedure they would stop the drug for a certain amount of time, but with the clinical trials it was found that it is not useful, as these drugs, they love the bone, and even after the medication has been taken, the medication does not wash out for a very long period of time. That is, the half-life of the drug is for long, like even 10 years. So the drug holiday has not been proved useful. So how do you treat the patient? There are 3 ways in which you can manage the patient. So if you see patient before the medication starts, and you could get the dentist to pull out the bad teeth, clean the infection of the jaw, treat the dental decay, and get the mouth in the top condition so that during the treatment the problems do not arise. During the treatment, the dentist should be on a lookout for the patients who complain of jaw pain, tooth pain, sinus pain, facial swelling, or difficulty in swallowing, because these are some of the red flags, and the dentist should be on alert for these ones. And if the clinician finds any of these signs, they should be referred to an oromaxillofacial surgeon, where it could be treated before something becomes a significant problem. For the individuals who have exposed bone of the jawbone is a dead bone. It's the dead bone that is exposed, and it won't be painful by itself, but it ends up getting painful when the bacteria in the mouth infect it. So the oral hygiene is to be taken care of, and the patient has to be instructed about the oral hygiene. The risk of role of antibiotics here is still a gray area. There are studies going on with the antibiotics, but they are given in patients with high risk or immunocompromised patients, and they would either give penicillin or clindamycin. In a scenario where you have to extract a tooth and it can't be saved, and there are multiple extractions to be done, so you would consider extracting a single tooth at a time. And after the extraction, the patient is reviewed from 2 weeks to 8 weeks, 2 weeks and 8 weeks for healing, after which you proceed with the next extraction. You do not create new exposed bone until the previous bone is healed. In a scenario where there are multiple extractions required, you begin with the symptomatic tooth first. Asymptomatic teeth with apical radiolucencies also should be treated, as the disease in the apical area is a risk factor for MRONJ. So this was all about osteonecrosis of the jaw. I hope you found it helpful. Thank you.